It's a little bit crazy over in the Capitol. We're all working our bills and waiting to exhale on the budget and a few other things. So it's a pleasure to be able to get across the street here and be a part of this panel. I see our panelists are all here, and it's a pleasure, but it's one of those things when Joe Cotto calls, you just ask when, where, how long, and do I have to buy dinner? Those are the questions you ask. And it's always, we will do anything for Joe. Joe is also, as many of you know, the past chair of the Latino Legislative Caucus. I'm the current chair of the Asian Pacific Islander Legislative Caucus, and I'm about to introduce the immediate past chair of the African American Legislative Caucus. So we all hang out together. That's the way to this works. We are now about to embark on a discussion for the Community Action Panel. And obviously, in terms of dealing with this issue of healthcare, all the different issues that emerge in all of our collective communities, looking at how they intersect, looking at how they overlap, looking at the continuity between one community and another is undeniable. Many of the issues that we all deal with are repeated and replicated in all of our communities, and also there's very specific differences that we can bring to bear relative to expertise and how to approach some of these issues. So in terms of this panel, we are going to be dealing with the issue of community action, but I just got a feeling in looking at the audience that this is a panel that a lot of you would honestly be good members to be a part of as well, because coming with all of this issue of healthcare, one of the key components beyond the health side of it is advocacy and activism. Absolutely. So let me introduce the first panelists, and we all have crazy schedules today, so if the other panelists don't mind, I'm going to have Mr. Swanson start, if that's okay. Sandra and Lee. Assemblymember Sandra Swanson, as I said, is the immediate past chair of the African American Legislative Caucus, but Sandra and I belong to the same caucus. And maybe it's, no, it's the old guys caucus is what it is. We're the old guys. But Sandra has a very unique distinction. He's the E.F. Hutton, and I know that's an old term that we use. Remember that commercial a long time ago about E.F. Hutton? He's the one we all listen to. People are jabbering away, and everybody's got opinions, and everybody's sharing the ideas. And then Sandra usually clears his throat, and all of us just shut up, sit down, and listen to what the brother has to say. It's because of his experience. It's because of his reputation. He comes from the Alameda County area, represents Oakland on every kind of board you can imagine. But the reason he is listened to by all of us is because he's a champion. He's a champion of the people that don't have the voice to advocate for themselves. He's a champion for civil rights and the rights of all people. And he makes sure and fights every day to make sure our communities get a fair shake. Ladies and gentlemen, Assemblymember, the Honorable Sandra Swanson.
Assemblymember Warren, for your time. He is my friend and a very principled member of the California State Assembly. I appreciate this invitation to come. Particularly, I appreciate it coming from Assemblymember Joe Cotto. We have had a long-standing friendship, and so I know what he's made of, and this is part of his passion to make sure that we pay attention to one of the most important issues of our generation, and that is the accessibility of health care. Let me say to you all that all of our experiences shape our opinion on this subject, and the older we get, the more attention we pay to the question of health care. My father is 82 years old, and I said, Dad, so I said, I sure hope I make it. He said, well, just do everything I do, and you'll be just fine. And I said, okay, Dad, I'll do everything you do. So every time he goes to an examination, he calls me. And he says, have you had yours yet? And so making it through some of the challenging examinations have proved to be very beneficial to me. But it took that kind of encouragement and that kind of mentorship on the part of my father to say, you have to go get that exam that most men don't like. And now, after I have had all those exams that most men don't like, I find myself asking, when I meet men of my age, I say, well, did you have that exam? You know, the one that men don't like. And a lot of them say, well, I'm scheduling that. And I say, well, that's an appointment to save your life. Because prevention is so much a part of the cure. And so from our own experiences, we can encourage our brothers and sisters to do the right thing and understand that given the advancements of modern medicine, it is important to take advantage of a strategy of preventative care. Now, I want to share with you as a legislator, our responsibility at this time is to try to make sure that healthcare is accessible, and don't let us off the hook by simply saying we don't have enough money. Start with what is right to do. How do we value the concept and the principle of accessible education? I have the pleasure for 30 years to work for members of Congress. And I remember as a young congressional aide working for Congressman Dellums at the time. And every year we put in a national health service bill. And it was called socialized medicine and a whole lot of other names. And so I remember we were meeting with some physicians one time in the early 70s. And they said, well, if we had a national healthcare system, how much would you pay physicians? And we said, well, we don't know. At the time, members of Congress were making about $100,000. So we said, I guess $100,000. And the physicians said, well, that's ridiculous. That's not enough. You know, although today, some of them might say $100,000 a year versus private practice makes a lot of sense. But at the time, it was seen as stifling accessible health care. But that's what members of Congress were getting at the time. They were getting, health care and health care for their family. And as someone that worked for 30 years for members of Congress and retired, so I have health care for life, and my family has health care for life. And every citizen in our country should have access to that kind of health care. And as you see, you may have because, as someone more eloquent than myself has said, healthcare should not be sold as a loaf of bread. We should see that as one of the rights of our society and one of the missions. It's not a question of money. Even though we face a $26 billion shortfall in our budget, and even though the first phase of this solution was to find $12 billion in solutions, and half of those came from the human services part of the budget, that still doesn't make that right. And I also contend that in the long run, if you do the proper economic analysis of what healthcare means to our society, you will find that the investment in healthcare in the long run saves our society a lot of money. Billions of dollars can be saved by us investing in prevention, by us making sure that there's in-home service care so people don't have to go to rest homes, that the economics of that system makes a lot of sense. And so we should never apologize for trying to advocate for better health care and for the investment in health care and for spending the money in health care. In addition to that, I believe sincerely that there is clear evidence that if in fact we are going to develop a new industry for our economy, new job opportunities for our economy, where we should be investing is in education, so that in healthcare, because there are going to be expansive opportunities there. And let me not talk too long, but say this to you, that since the 70s, when as a young congressional aide, that I have been advocating for the accessibility of healthcare and opportunity, I will tell you that from the early 70s through the ambitious ideals of Jimmy Carter, through the proposals of the Clintons, until now, as we are presented an opportunity by our 44th President of the United States, Barack Obama. I will tell you there has been no other period of time where the opportunity hasn't been greater for our advocacy, for us to do the things that we have all dreamed of doing, and that is to make healthcare accessible, for us to pound away on the principle and value of accessible healthcare for all Californians and for all Americans. And so now our president has given us an opportunity. And this is a time for our advocacy to double, not for us to shrink, not for us to apologize, but for us to advocate so that we can get this accomplished when we have a president that is trying to address this question. And finally, as you know, the debate has been in Washington around the elimination or trying to balance the budget on the backs of Medicare and Medicaid. And there's pushback from both sides of the aisle because it's working for people. And I think that provides us another opportunity to say, what is it and what is the role government should play in this debate around health care, and what do we deserve as citizens of this great nation? And I think that if we have an honest debate about that, we will be able to solve this problem. As the past chair of the California Legislative Black Caucus, I appreciated working with Senator Cotto when he chaired the Latino Caucus, and my brother Warren, and trying to keep this issue in the forefront. We had a youth health fair. We were generously sponsored by Kaiser Permanente, and we invited families to bring their children. 450 families showed up on a Saturday. We had free dental screening. We had free obesity screening. We had free haircuts. We gave away a bicycle every half hour to the kids that were there. We made health fun. There was demonstration on how much sugar is contained in sodas, and there was explanations about diabetes and predispositions that families should be concerned about. And they should tell their children, and it should be passed on through generations so that we can pay attention to diet. And it was the most wonderful experience that I've had as a member of the legislature, to see those smiling faces and to have people identify problems. And to have people identify, to be told by a physician where you should check that spot out on your skin because it may be cancer. I mean, that was an opportunity that I think shows the importance of this mission. And so I thank my friend, the Honorable Joe Cotto, for organizing this event, all of you for your advocacy for health care and the important mission that you're on. We will win this one, because it means the lives of our children and the next generation. Thank you all, and God bless.
Thank you very much, Sandre. As Sandre mentioned, and through the leadership of Joe Cotto, all three of our ethnic caucuses have been working on the issue of health care and the issue of access. This last year, I was able to get the state auditor to do an audit on the Eligibility Act of the early 1990s. And the Eligibility Act was simply an act making sure that the services provided by the state would be done in languages that many in our community would understand easier than English. And the result of this audit was that an absolute failure almost on every level. So we're not only talking about healthcare issues in terms of what's going on in our community, but we're talking about how to access them. And that's where the community action comes in. For the Asian Pacific Islander and Native Hawaiian community, we have issues obviously in relationship to cancer being the #1 disease that is a killer in our community. We have issues where specifically tuberculosis and hepatitis B impact the Asian American, Pacific Islander, Native Hawaiian community at a higher rate than any other community. And along with so many of our communities, the issue of diabetes and any number of different health issues have a tremendous impact. As we talk about the health issues, the ability to communicate to our community members about what these issues are and the problems. I mean, we all have stories in our own families where the 10-year-old kid gets brought in to be the interpreter at court, gets brought in to interpret at the doctor's office for a lot of members in our family. And, you know, as charming as that may be to some people, it doesn't get the job done. So there's a lot involved in this, and our next speaker couldn't be a better person to have up here to talk about it. Unfortunately, this is the first time I've met her, but her resume is extraordinary. Someone that is doing this for 25 to 30 years in terms of being a community advocate. She is the governor-appointed director of the California Office of the Patient Advocates. She has been a part of the organization and leadership that establishes the state's annual healthcare quality report card, and also in terms of looking at things about information, how to use your health plan has been a multiple language award-winning guide that people have been able to call on. Mrs. Perez, as I said, has been doing this for a while, and to prove that, she used to work with Willie Brown and Assembly Eisenberg, so she knows what's going on across the street. Ms. Perez has a Master of Arts degree from Harvard University Kennedy School of Government, a Master of Science in Health Services from the University of Southern California, a Bachelor, this lady's got education, ladies and gentlemen, and I look forward to getting to know you more, Sandra. With Sandra Perez, Director of the California Office of Patient Advocates.
Thank you, Solomon, for that very generous introduction. Thank you, Mr. Cotto, for having this event. Healthcare is very dear to my heart. It has been a long time. I can't believe I'm still working on this. But you know, it's one of those things. It's one of the things I say that everybody has healthcare. There's one thing to be an advocate for education. We're not all into education, but everybody needs healthcare. So thank you for doing this. I'm also curious, how many people in the audience are working in the legislature? Okay, and how many work in the healthcare system? How many in academia? Not-for-profit organizations, great, okay. Well, you know, we talked about community action, and we've heard today there's a role for everybody, and the roles are changing, so there's lots of opportunity. I do think change is always an opportunity to improve things. So I am the half-full kind of person too, but there's a lot of work to be done. As he's getting this up there, I'm just going to say, what I'm just going to do today is give you a very brief overview of what the Office of the Patient Advocate does. The name is a little bit misleading. People think that I'm responsible for 38 million Californians taking care of their health care. I can't do that. We are a small office within state government. We work closely with the regulator, the Department of Managed Healthcare. As they were created about 10 years ago, somebody said, what about the patients? And that somebody, a lot of you might know here, is Marty Gallegos, who was a former Assemblyman. So his legislation is what gives us our authority. I think in a nutshell, if I was going to just jump to the punchline, because I do know it's quite late, I would say there's 4 messages that I believe with folks. And the number one is, it's already been said, coverage does not equal access. And at the Department of Managed Healthcare and Office of the Patient Advocate, we are looking at the commercially covered population. However, we know that our efforts actually affect other covered folks. Another message is that the quality of healthcare that you receive does vary. It varies by provider, by health plan, by geography, by ethnicity. So the quality of care varies, and that's a really important message I like to get to consumers. Another message is you can't change what you don't measure. So you'll see one of our mission is to create a report card measuring the quality of care that providers give. And finally, I would just say our healthcare system, as it is, requires consumer engagement. Unfortunately, it requires consumer engagement. And I do have a master's in health services administration, and how do I choose my health plan? I probably ask my best friend, what do you have, right? So it's very, very complicated. I was going to show you a video. I don't know, it's not there. Okay, I usually show video because a picture, and especially being the last speaker, it really helps show you what we do. It's basically 30 seconds. It's produced by the federal agency, which is a sister agency, the Agency for Healthcare Quality Research. And it's a PSA you may have seen on TV. Basically, the guy is the previous Swanson said, it's like selling a loaf of bread. Well, here we have a PSA that's showing somebody buying a cell phone, and it's asking all kinds of questions about features and data and conversion. Does it have all these features? And then he answers, the salesman's answering the questions. Then it changes scenes, and he's in the doctor's office, and the doctor will say, "Do you have any questions?" No, I have no questions. So it's something that's our challenge. We're trying to change a culture about people and their engagement in their healthcare. So, very quickly, I'm going to try to do this. How do I do this? Talk about technology. Okay. Office of the Patient Advocate. Small office, we're 11 people, just so you realize how small we are. Our mission is to represent the interests of the health plan enrollees. We do that in 2 ways, by educating consumers, and it is specific in our language, thank you to Marty Gallegos, that we must do this in multiple languages, and we do. We have award-winning guides that we have produced with UC Berkeley. We also must publicly report annually a report card, including but not limited to HMOs. And I'm proud to say in the last 10 years we've been able to expand that report card from just HMOs to now, most recently, PPOs. We also do a report card of medical groups. Medical groups is the most local data that we can get. Yes, we're going to begin to focus on physician level data, but it's a very big challenge. Okay, in a nutshell, what we do is 3 things: public reporting, patient rights, and partnerships. All of these require working with many, many stakeholders, and I hope to, what I want to do is invite you to become one of our partners. And I'll talk about that a little bit later, but public reporting is a very complicated science. The measures that we want to publicly report come from, like the National Quality Forum in DC, the NCQA, what measures are available, which ones are reliable, which ones are useful, and it goes through a long stream. So we have many stakeholders there. I invite you to get involved in that. They actually look to consumer advocates to help them decide which measures to go on. Patient rights, of course, very, very important aspect of our work. And with healthcare reform, I take that obligation very seriously now. And then partnerships. We can't do it by ourselves. And in fact, you all may have heard the executive order yesterday, the governor said, no in-state travel. So in a state as large as ours, for us to reach everybody, we really can't do it ourselves. Somebody went to Bakersfield today, my staff, to talk to the business women, but we won't be doing any more travel. So we really need your help to reach all of your organizations, your constituents. I did work for Eisenberg, Willie Brown. I've worked in district offices before. I know that you need materials to give to your constituents, and the Office of the Patient Advocate has those. So just really quickly, I'm just going to go over the public reporting. These are basically cover sheets to our report cards. We have a printed version and we have an online version. On the left is a printed version. It's a 2-sided card. You might find it in the back table over there with Martha, who can help you walk you through these documents. It's the first time we've had an HMO and the PPO report card on the same page. Many in the industry would say it's not fair because you're not comparing apples to apples, So nonetheless, it is what it is. And it's supposed to attract consumers to go to our website. On the right-hand side, you have our portal page, which is basically one-stop shop. You can find quality data there or links, at least to Medi-Cal, PPOs, HMOs, PERS, CalPERS, et cetera, et cetera. So just to give you an example, at diabetes, you got to go to our website because I just don't have time to go over it. But on the diabetes condition, we have many conditions. Diabetes is one. This is an overall score on how the major health plans in California do. And this covers 90% of the commercially covered population. So besides the overall scores, however, you can drill down, is what we call it, behind the curtain and see what are the scores that build into that aggregate score. Here, the most important ones are testing, of course, for blood levels, and then controlling that blood sugar. I just really need to introduce you to this because, let's see here, this is on controlling blood sugar. And you can see the plan does do vary a little bit. And that white space that you find there those represent people. And for me, that's where the plans need to do better than at controlling blood sugar. The green line is an ability to compare to the nation so that you can see how California compares to the top 90 percentile across the nation. So this is a picture of our printed guides done in conjunction with UC Berkeley. And I want to say, before I move on to what we do there, I just want to say at the report card level, action, what can you do with the report card? I can give you a few examples. I've had folks from Bakersfield come to me and he said he took my medical group report card page of diabetes and he went to the local medical group and he said, look, you guys are doing so hot in this area, you know, what are we going to do about this? And what came out of that conversation was a consumer education fair. And so they went into the community, it was Fresno or Bakersfield, and taught people about the importance of controlling your blood sugar. So that's one way. Other things, of course, the industry looks at this report card seriously. And providers are very competitive, and it stimulates a lot of competition. You know, I see disease organizations, diabetic organizations, the cancer folks. Take a look at this, because we have one on cancer too. And then for policymakers, we have a new measure on the report card. Again, before I leave it, the report card has a new measure using BMI obesity whether they use the BMI to discover if obesity has something to do with their illness. And I don't have those slides up there, but they're very discouraging, especially treating children. So we hope that organizations and advocacy groups will begin to use that data. Here are the guides. The guides, that past slide here, those guides are at no cost to use, just so you know. Okay, one of the things that OPA does is we promote the health center. There is a gold nugget in state government. It really is a treasure. The health center will help you with your health plan. They are a staff of about 90. There's about 66, 30 on the call center that will take your call. There's nurses, there's attorneys who will advocate on your behalf. So I just encourage you to let your constituents know about this phone number to call. They also do a service called the Independent Medical Review. When you disagree with your health plan's decision on equipment or services, Independent Medical Review, you can have one. And the success rate of that is very encouraging. It's about 60% of those complaints that are submitted, the decision is actually overturned. So it's, I really encourage consumers to look at the health center. We also educate consumers, like everybody, I think, the social media stuff. Very important, but this is where you can partner with us. You can take our badge, put it on your website, and there's many other things you can do. I'm going to point to Martha in the back there because she'll be able to customize how we can partner with you and your organization. Partnerships, super important. And I'm super happy to hear that we're doing the partnerships again. We did have to stall for 1 year, but our past experience and our heroics program, which many of you might know about as nonprofits, really leads us to some good experience for the future. So, wrapping it up here, something else I think all advocates should know about are 2 other resources at the state level. This is the website from the state on healthcare reform and where the state of California is on healthcare reform. There is a tab up there that will be addressed to healthcare and you, so it will be addressed to the individuals. So it's healthcare.ca.gov. And another resource is the PSIP program. I hope you all know about the pre-existing conditions program. That's temporary, but some of you know about it. Anyways, for those who have been denied insurance coverage because they have a pre-existing illness, and if you have been for 6 months, Diane Dooley's shop actually has this program. It's part of healthcare reform. It's a temporary thing, basically, to the year 2014 when everybody's going to be covered. So, with that, come and partner with OPA. visit our website, leave your card with us, whatever it takes. I really want to get the word out, and I just really need to work with you. So going back to my messages, I just like to say, remember, you can't change what you don't measure. Super important. And then coverage, just because you have a card doesn't mean that you have access. And we were able to address some of that with the language, the SB 853 from Marta Scutia, that became a bill, became a law last year, and I was really, I'll tell you, it made a difference, because I went out across the state doing the Dog and Pony show about SB 853 in Spanish languages television, and we saw the number of calls go to the health center by about 4,000%, and that was in Chinese and in Spanish. So there is a super demand out there. I will hope that you will help me get the word out more. And finally, we just need to engage consumers, and it is a complicated system, but we need to engage our consumers. Finally, I welcome your ideas. If you have any ideas, suggestions how to reach more people, I'll be here afterwards. Thank you.
Thank you very much, Sandra. Just in hearing what you were saying about a lot of these issues of partnering and working with the community, as we were saying relative to the Diamond Aleatory Act, the different languages that are spoken in California, for the Asian American community, Native Hawaiian and Pacific Islander, we lump everybody together, but really the disaggregated information is really critical to see how different communities are affected. The Asian Pacific Islander community is 15% of the state's population, according to the most recent census numbers, one of the fastest growing communities along with the Latino community. But as with the Latino community, there's a lot of other groups within that group that may speak similar languages. In the case of Asians, that's not true. Everybody speaks a different language. So different generations, whether they come here as immigrants, whether they come here as refugees, people relate to government and government systems and government services in a lot of different ways. Again, not having a chance to meet our third presenter before today, I was looking at his name, and it was an interesting combination, first name Leaf, and then I thought, wow, I've never heard of been a Japanese American with the first name Leaf, because I thought the last name was Halise, but it's not. And Leaf is currently a California-based senior fellow of the Health Policy Program for the New America Foundation. I don't know if you've got this on your table, but a really good piece that he's written. And he is an author and a researcher, educated at Yale and Princeton, but really he has been most recently an executive director of the California Task Force on Affordable Care. And so this man knows what he's talking about. We will have questions for Sandra Henley after this last presentation, so we can have a bit of interaction. So, Lee, please.
Thank you so much, Warren, and I'm delighted to be here today and participate in this summit, and to be the final hurdle between you and the reception. Yeah, Hutton was mentioned earlier, so I want to reach back in my memory banks to another show of the 1970s. You may remember the Gong Show. I'm deeply grateful that there's no gong in the back of the room to announce my impending departure. As Warren mentioned, I'm with the New America Foundation. We've been heavily involved over the years in trying to get comprehensive health reform, both in Washington, D.C. and here in Sacramento. And in that vein, I want to mention Joe Cotto and the Latino Community Development Foundation have been among the most dedicated champions of an approach to health that recognizes the importance of expanding access and insurance coverage, but also the need for community action and personal responsibility, which have been big themes of New America, and particularly with respect to the obesity crisis that cuts across all generations. It's rare for me to be without slides. As Warren mentioned, in penance, I brought along a issue brief fact sheet that should be in all your tables, called Making and Breaking the Health Wealth Connection. In the gist of this paper, in this very short presentation, is that the Affordable Care Act, if implemented as passed, will greatly improve the financial security of low and middle-income Californians. It'll do so by equalizing access to high-quality, affordable insurance coverage, making it easier to avoid medical debt, lowering the hassle involved in becoming eligible for Medi-Cal and other public programs in California, and getting a credit toward the purchase of health coverage from the newly established California Health Benefit Exchange, and finally by giving individuals and communities the tools to improve health disparities in their own neighborhoods. And I really want to stress that final point, because the more obvious impact of expanded insurance coverage is reducing the burden of medical spending for Californians, protecting the wallet, as it were, from unexpected medical bills like spending several days in the hospital that can eat up all your assets. But it may also be true that financial security in the form of a bank account, a stock portfolio, may itself be an independent determinant of good health, much like, as we know, education or good nutrition. This is one of the things we're working on at New America, and that we plan and hope to share with you over time. Lots of people, even some backers of the Affordable Care Act, think of it as a laundry list of things related to health care, sort of a hodgepodge of ideas, and that's true even if you're a backer of it or not. I want to suggest otherwise today, and this is part of the Community Action and Advocacy team. Whether you like it or not, it's more like a body with a heart, with a brain, and with limbs. Atul Gawande, the medical writer and surgeon, said when the Affordable Care Act was passed, it's, the frightening thing about it is not really that it's a government takeover, but that it depends on the actions of doctors, of communities, of medical groups, of different small groups of people throughout the country, from states to regions, to make it work. That's the really scary thing about it, and that's in some ways the challenge that I present to you today. The heart of the reforms, of course, are about access to insurance and medical care, and in particular bringing the availability of decent coverage that's available for many employers and from some public plans and programs into the range of most Americans. In California, this means making insurance coverage available to numerous communities and people of color where the number of uninsured have been highest, and in particular because of categorical eligibility rules for Medicaid, Medi-Cal. Preachers sometimes remark that everything we're saying has been said, but not everyone has heard it, and I say that with some trepidation because there is at least one minister here in the audience. But it feels a bit that way talking about the insurance provisions of the Affordable Care Act, but it really bears repeating that the Act will greatly expand coverage for people of color in California. As you can see in the paper, according to the Lewin Group, an estimated 3,180,000 Latinos, almost 500,000 African Americans, and almost 1 million Asian Americans will be eligible for Medi-Cal coverage or for subsidies in the exchange in 2014. And along with the recently passed legislation forming the California Health Benefit Exchange, and there are multiple bills in the state legislature aimed at reconciling the federal law with state law, we've also had the waiver that many of you know about, the Bridge to Reform, which is a very timely expanded renewal of an earlier 5-year waiver. And as a result of that, California's 58 counties may be able to provide coverage to up to 455,000 uninsured adults in advance of the bill implementation of federal reform in 2014. Again, many of minorities and people of color. And finally, one thing that isn't thought about too much in the Act is that $11 billion in this Act will be directed to federally qualified health centers, community health centers, which specialize in caring for the uninsured and low-income Californians. Roughly $1 billion of these funds will be spent in California over the next 5 years. And we know that over 3/4 of visits to these community clinics in California are made by people of color, principally enrollees in Medi-Cal and healthy families, or the medically uninsured folks paid for in the counties. To put this in a bit of perspective, as John Gruber and Peter Long did recently, the net effect on household budgets of families in California, the combination of taxes and benefits, for families between 133 and 200% of poverty in California, it's an increase of $5.5 billion as a result of the Affordable Care Act, some $2,000 per family. And even for families in more upper ranges, 200 and 399% of poverty, you're still getting back twice as much as you're paying in. As I mentioned in the paper, a little bit of length, the reforms will help Californians, young and old, reduce and eliminate medical debt, largely by eliminating the kind of insurance plans that have caps, that don't provide enough hospital coverage, or are just simply junk insurance plans to start with. It won't be a panacea for medical debt, because obviously the plans in the exchange will still have substantial cost sharing and out-of-pocket payments and premiums, but it'll help a lot. And so will provisions in the Affordable Care Act that eliminate the coverage caps, and particularly that offer relief when a patient's income is, spending on medical care is too high a percentage of their income. The brains of the legislation, to continue this metaphor that now forgotten, in my view, are about the various efforts to contain health costs, which I've done a lot of work on, and in particular to enlist doctors and physicians in the mid and long term in this effort. These embody a culture of trying to change incentives rather than regulating prices, and they're largely about behavior and cultural change. So it's really hard to know how much money they're going to save over which time period. And because this is about the brains and it's late in the afternoon and it's hard to think at this time, I'm going to pass over that and move on to what I think of as the limbs of the Act. And this is what relates particularly to the community action theme of the panel. What the drafters of the legislation realized, and it's actually pretty rare in healthcare legislation, is that insurance coverage is a necessary but not a sufficient part of creating a healthy community and society. They realized that access to medical intervention is really not the key to health care. That access to health insurance improves health outcomes, but it's far from the most important factor in determining whether individuals stay healthy over their lifetimes. The effect of physical and social environments in combination with individual behavior plays the most important role. And it's in the ACA, and what I think of as the limbs of the bill, that there are numerous and varied opportunities to address disparities and the social determinants of health. For example, legislation created really an unprecedented prevention and public health fund aimed at promoting prevention, wellness, and immunization programs. The appropriations are pegged at $7 billion from 2011 to 2015, and $42 million has been spent already in California. Provisions are also included to require chain restaurants and owners of vending machines to disclose the nutritional content of their food items. And it also explicitly acknowledges the key role of community action in promoting health. For instance, community transformation grants, and that some CTGs will be awarded to programs that help support healthy lifestyles and set priorities for reducing ethnic and racial disparities in health at the community level. And we've seen it here in the legislature currently, bills like 86, Fuente's bill to reduce eligibility determinations and fingerprinting for CalFresh, the SNAP or food stamp program, is a great example of this kind of connection between the social determinants of health and public policy. To go back and to conclude with Dr. Atul Gawande, he argued that pilot programs in agriculture, which were initially small, made the U.S. into the world leader in food yield and agricultural innovation. And I'd argue that the Affordable Care Act is trying to do a similar thing for health care. The really radical thing is that we're making a series of little bets in the Act, to use the title of a recent book by Peter Sims, and it won't work at all unless we are all pretty actively engaged in it. It is, in effect, how all the arms and the legs of the Affordable Care Act work that may determine whether it moves forward or grinds to a standstill. Thank you very much.
Thank you very much, Lee. Mr. Cotto, I understand the reception starts at 5:40.
Yes, sir, right now.
So we can handle a couple questions.
A few questions, and then we'll break the reception.
Do I pay for dinner?
Yeah.
Always have to ask that question, Control. Opportunity, absolute policy expert. I've been trying to figure out this healthcare stuff. I learned a lot just sitting here. Sandra is someone that implements, makes this thing happen. Questions from the audience or comments? Yes, ma'am. Yes. Stand up, please.
We know from earlier work of
Could you
that.
use the microphone, please?
And then maybe
coming.
Thank you.
and identify yourself.
I think we heard.
Good. It's
And
on.
could you
Good.
identify
Yeah.
yourself also?
Hi, I'm Ann Payne.
No.
I think we heard earlier a reference to the work that that Endowment is basing their work on about community stability and its contribution to health outcomes. And so this, my question is following up on that for Leaf Heights. If you could give us some sense, not knowing your results, of course, because you're still in the midst of it, where you're going, the study you made reference to.
Well, I'm not with the endowment, but we're happy.
No, but what you're doing in New
We're doing it.
America,
Right.
that's
Yeah.
building on that.
Sure. The goal really of what we're doing is to try to determine whether financial security in the form of different kinds of asset building, of perhaps of building wealth, actually plays an independent part in folks being healthier. We know that there's great work that's been done over the years, of course, in education, in nutrition, and in what I think of as sort of inter-community stability. We all know that those things play a big role in promoting health and in people living longer. And Tony Icon's name came up earlier. If you haven't seen the PBS special, which features him on social determinants, I urge you to go out and get a DVD. But a lot of the work we do at New America is indeed about trying to build financial security for low and middle income folks. And we think there's a strong connection between the health of the community, and not just as a metaphor, but actual health. I mean, if you think of it, of course, just simply the stress that's caused by being in debt is a major risk factor in illness. So those are the sorts of things we're trying to tease out in a systematic way.
Yes.
Hi, my name is Elena Ong,
Oh,
and I'm
Elena.
the Communications Chair for the American Public Health Association Asian Pacific Islander Caucus. And I was very excited that the Affordable Care Act passed, and very excited that healthcare.gov was available in English and also in Spanish. And so I just kind of said, well, Judy, how can we get this translated, and my comment, how can we get this translated in Asian languages? And Sandra, you've been such an incredible leader dealing with the PPO and the HMO experience, but we don't have the same thing going on the non-PPO side. And I was wondering to what extent, being that 1/3 of all Asians live in California, how you can actually be that resource for the rest of the 2/3 of America that are going without. And I want to give you a challenge, both of you, because one of the things that I really felt a tremendous need for was education on the healthcare tax credits to small business owners. Not as much as the patient advocacy type stuff, but making sure that small business owners, for the most part, who were monolingual, non-English speaking, had access. So I was wondering if you guys would pair up, actually, and kind of do tax clinics.
We'll talk about that afterwards. But to answer the easier question here, the website, that's a state health website. Actually, it's ran by the Health and Human Services Agency. But they did receive a grant from the healthcare reform, federal government, to improve that website. So that money has now been, started here. It's a procurement process, but the Department of Managed Healthcare is the lead on that grant, and they are going to be working with Health and Human Services to improve that website. And I will be the first to suggest they do it in Chinese, as our own website is in Chinese and Spanish and English. So.
I want to give a shout out to my friend John Ahrensmeyer with Small Business Majority, who many of you in the room may know, who's been putting together a really super website and set of materials aimed at small business in California, across the country, that really explain, and not always just a cheerleading way, what's in the Affordable Care Act that can help small business. So he's another one I'd say would be interested to partner with you.
Questions? Is that Assemblyman Michael Allen back there? Is it?
Ask him to come
Let
up
me
and
introduce Assemblymember, I'm sorry, Mike, his lights are on my Joe asked if you'd come forward and say a few words.
Yeah, I'll make it a few words.
Steps right on the side.
What do you want me to do?
A step on that side if you want.
Oh, right there. Do it right here.
Okay. I will make it a few words because I know you've been in conference all day. I know you've probably had a number of speeches. First of all, I am Assemblymember Michael Allen. I represent Napa and Sonoma and part of Solano County. Just a little bit of my background. I call myself the undercover member of the Latino caucus. My mom's Latina, my father Scottish extraction. I'm actually living proof of what it means to be here in California. My mom immigrated in the 30s to California. I was a product of the public school education, and I went to nursing school. I became a registered nurse. I was an intensive care nurse at Children's Hospital in Los Angeles. Then I became a psychiatric nurse up in Sonoma County, and that psychiatric background helped me greatly in my future endeavors in the legislature. And then I followed up by going to law school at night and working for the Sierra Club, and then ultimately working for working people and labor unions. I will tell you this, that the amount of money we spend in this United States of $2.5 trillion, I think it's something in the nature now of 70% of our gross national product is going to health care. And what I really see is that there needs to be much more emphasis on lifestyle changes, prevention, early education. I saw a startling statistic where it said that the World Health Organization had done a study and found out that 75% of the Latino population in America got their main health information from television. So obviously there's a huge gap that needs to be fulfilled in getting the word out as to healthy lifestyles, ways that we can change the way that we live so that we can prevent illness before it even starts. But I will tell you that the legislature is going to be very much involved in the healthcare debate and reform now that it's been passed at the federal level. And that I'm very confident that someday, hopefully not too far in the future, we'll see Sheila Kuehl's bill that Mark Leno took over and now is reintroduced. I can tell you for 30 years I've been an advocate for single-payer health care. We have to wring out all the administrative expenses out of health care to really get the most for our dollar and to really have a healthy society. If we do an outreach in education to the Latino community, not only is it going to be a benefit to that community, but to our entire society. So I promised a few words. I've probably gone too far already. Just thank you so much for being invited here. Thank you.
How about a big round of applause for Warren Portani and scheduled, as presented earlier today, the chair of the Senate Health Committee, Ed Hernandez, who has done some exemplary work in the legislature. He is here now, so we're going to give, again, the chair of the Senate Health Committee, who's been a champion, by the way, of health care disparities and is very passionate about the issue. So please, a big round of applause for Senator Ed Hernandez.
Good afternoon, and thank you very much for the kind words and the kind introduction. Good friend of mine, former Assemblymember Joe Cotto, called me up a couple of weeks back, or a month or so. He said, I've got put this together. I'd like to know if you'd be willing to come down. I said, of course. I do apologize. Unfortunately, I had a very, very busy day. We were in committees all day. I literally just got done. But I'd like to take just a little bit of your time. I know the day's getting close to ending. You're probably tired. But I want to talk to you about workforce and the disparity amongst Latino communities, and the biggest problem facing what I believe was the healthcare crisis that we have. And being chair of the Senate Health Committee, my absolute number one priority is going to be, number one is the implementation of the federal health care bill. Because we have so many unknowns we have to deal with. We have to deal with the medical home model, the ACO model, how that all works. The second priority is going to be dealing with, in light of all the drastic cuts we did to health and human services, how are we going to be able to continue to provide that same service, unfortunately, with less money? But more important, how do we increase the ranks of our Medi-Cal provider list? Because I think the biggest problem we have here in the state of California, we have such a poor provider list. But then that brings me to the third item, and I'm going to kind of tie that into sort of what you've been talking about today, and that's the workforce problem we have. Let's say we were to wake up tomorrow morning and every single person has health insurance coverage. Every single person has low deductible, affordable, and everything's covered. You know what? It's not going to solve the problem that we have here in this country, especially in the state. And the reason why it's not going to solve the problem is because we have a huge workforce shortage. And the workforce shortage we have is predominant, let me restate this, predominantly in low-income communities of color and rural communities, and those are the African American and Latino communities. And I am convinced that we have a two-tiered healthcare system. A two-tiered healthcare system, one for the poor and one for the wealthy in the state. The wealthier individuals in those communities have a higher per capita number of physicians and primary care providers, and also the majority of those patients are in private pay insurance. The communities that I come from and the communities of color have the lowest incidences of per capita of physicians to patient ratio. And guess what? Most of those patients are on Medi-Cal. Here's the other problem that we have. With the reduced number of Medi-Cal reimbursement rates, we continue to have fewer and fewer providers that, number one, go to those communities but take Medi-Cal, thus making that even worse. And here's the most devastating thing, is that those are the communities that have the absolute highest incidences of chronic diseases in this country. Diabetes and high blood pressure. And if you want to talk about the largest cost drivers of healthcare, there's mainly two of them. It's chronic disease and end of life. So if we're really going to make a difference in healthcare, we need to address the workforce shortage we have, but make sure that that workforce shortage is in the communities that need it the most. But I want to go even a step further, because if we're going to increase the workforce shortage, I also believe we need to look at that workforce shortage to make sure that we have a diverse workforce shortage. We have, I'll give you an example. If you have an individual who comes from a particular community, who goes to become a physician, a dentist, an optometrist, a nurse practitioner, that individual is more likely to go back to that community, and if that individual does a residency program, is going to have a higher propensity for staying in that community. And I am such a huge advocate that we need to make sure that we get more individuals of color and Latinos to go into the health professions, to take more science courses, because those are the individuals that are going to come back and service those communities. So if we're really going to address healthcare, we need to look at the workforce shortage, but the diversification of how we address that workforce shortage. And more important, how we're going to get those kids to go through there to address those needs. And then the final piece of the puzzle that I'm going to work on as Chair of Health is how we're going to reduce overall healthcare costs. Because we all know that the premiums go up in health insurance companies, but if you think about it, they go up because of the increased medical costs. But we need to really look at across the board. We have to look at transparency with the physicians, with the hospitals, and the insurance companies. But we need to take advantage of the federal government, what's going to happen with PPACA, how it's implemented, examples of how we can reduce transparency and make sure, as I mentioned earlier, is the ACO model, make sure that we have an all-claims data payer base, to make sure that we have electronic medical records, so that we can share all this information to make sure that we're getting the best bang for our buck with regard to healthcare. So with that, Joe just asked me to come up and spend a few minutes. I'd like to take this opportunity to thank Assemblymember Cotto. He's a good friend. I apologize for not being here sooner. I want to thank all of you for being here today. And of course, I want to thank my good friend and my brother here, Warren Furtani. He's also a good friend of mine. And thank you very much for giving me the opportunity to speak this afternoon.
How about that? Both Michael Allen and Senator Hernandez, a big round of applause for them. We have